You're about to be put under general anesthesia. Perhaps it's scheduled for tomorrow, perhaps in a few days. And right now, fear has taken hold of you. You want to understand what will truly happen, not the polished, reassuring explanation they hand you at your preoperative appointment. The unvarnished reality. What actually takes place inside your brain, your body, your awareness when they send you into that chemical darkness. I'm going to lay all of it out for you, because you have every right to know. My name is Dr. Dan Carter. Across years of practice, I've witnessed this sequence play out thousands of times. I've watched people slip away from consciousness in a matter of seconds and resurface hours later with absolutely no recollection of the interval. I've seen everything proceed flawlessly, and I've seen it go sideways. What I'm about to walk you through is the reality of what unfolds inside that operating room, the science behind it, the dangers involved, the details your medical team may gloss over because they'd rather not frighten you. But you're here because you're after the unfiltered truth, so let's get into it. Let's start with the question that haunts nearly everyone, even if they're reluctant to voice it. Could I become conscious during the operation? The phenomenon is known as anesthesia awareness, and yes, it's a real occurrence. But before alarm sets in, consider the actual statistics. It arises in approximately 1 to 2 out of every 1,000 procedures. That translates to 0.1 to 0.2%. Your odds of being hit by lightning over a lifetime are actually greater. Still, it does occur. And for those who experience it, it can be profoundly traumatic. People who've gone through it describe a state of full paralysis coupled with wakefulness. They recount hearing the surgical team's conversations, perceiving physical sensations, being completely unable to signal that they're aware. Safeguards exist to prevent this. Brain activity monitors, meticulously calibrated drug dosages. But medicine is an imperfect science, and that's something you should be aware of. Now let me walk you through what actually takes place as you're put under. You're lying on the surgical table. Overhead lights glare down. The room is frigid. Intentionally so, because cooler temperatures inhibit bacterial growth. The anesthesiologist is beside you. They've introduced themselves. They've reviewed your file. They're familiar with your medical background, any allergies, your anxieties, and they're on the verge of doing something that is simultaneously awe-inspiring and deeply unsettling. They're about to shut down your conscious mind. Let that sink in. Consciousness, the very essence of who you are, the sensation of existing, of being present. They're going to chemically extinguish it. And then, once the surgeons have finished opening your body and repairing whatever needs fixing, they'll reignite it, as though toggling a light off and back on. Except it isn't a simple toggle. It's a precisely choreographed chemical intervention targeting your brain. Here's the sequence of events. It begins with pre-medication, typically midazolam, a benzodiazepine. It accomplishes two things. It eases your anxiety, settling your nerves. And, this is the part that unnerves many patients, it induces anterograde amnesia. Anything that occurs after the drug is given will be wiped from your memory. You could be chatting with nurses, cracking jokes, signing paperwork, and afterward, you'll retain absolutely none of it. Your brain simply ceases to encode new memories. Next comes induction. You're instructed to breathe deeply from a mask delivering pure oxygen. This is called pre-oxygenation. The reason is straightforward. Within roughly a minute, you'll no longer be breathing independently, and the anesthesiologist needs your blood loaded with oxygen to create a safety margin while they take control of your airway. You inhale the oxygen. Then propofol enters your intravenous line. Propofol is a milky white liquid. Operating room staff sometimes nickname it milk of amnesia. It stings as it flows in. Patients frequently describe a searing sensation traveling up their arm. That's expected. No tissue damage is occurring. The drug simply irritates pain receptors as it moves through the vein. But the discomfort won't concern you for long. Within seconds, you vanish. And I mean that literally. Propofol acts faster than virtually any medication in a clinician's toolkit. 8 to 10 seconds from injection to total loss of awareness. Your eyes drift upward. Your muscles go slack. Your breathing ceases. You've entered a state that, in practical terms, closely resembles death. Your awareness has been extinguished. From this point forward, keeping you alive falls entirely to the anesthesiologist. Here's where things become fascinating. We still don't fully understand how anesthesia produces its effects. We can observe what it does. Brain imaging reveals the consequences clearly. But the underlying mechanism, the precise way these chemicals strip away consciousness, remains an unsolved puzzle. Hypotheses exist. The leading theory proposes that anesthetic agents sever communication pathways between distinct brain regions. The prefrontal cortex, responsible for self-awareness and higher reasoning, becomes isolated from other areas. Your brain loses its ability to weave information together into a coherent whole. Without that integration, consciousness cannot exist. What remains is scattered neural firing that leads nowhere. But let's return to you on the table. You've stopped breathing. The anesthesiologist takes over. A mask covers your face. Air is manually squeezed from a bag into your lungs. Your chest inflates and deflates. Monitors track every vital metric: blood oxygen, pulse, blood pressure. All of these shift the instant consciousness leaves. The airway must now be secured for the long term. You'll be unconscious for an extended period, and manually squeezing a ventilation bag for the entire duration isn't feasible. So the anesthesiologist intubates you. Your mouth is opened. A laryngoscope, a curved metallic blade equipped with a small light, is inserted to bring your vocal cords into view. A plastic tube is guided past them, down into your trachea. This tube links to a mechanical ventilator that will manage every breath you take. Intubation is a refined craft. It demands years of training, and it isn't always simple. Certain patients present challenging anatomy, structural features that make the vocal cords hard to visualize. When difficulties arise, alternatives are ready. Video-assisted scopes, specialized devices. In dire situations, a surgical opening can be cut directly into the airway, but the vast majority of the time, it proceeds without incident. The tube slides in. A tiny balloon at its tip is inflated to anchor it in place. Correct positioning is verified by listening to both lungs. You're now connected to the ventilator. But unconsciousness isn't the only state you've been placed in. You've also been rendered completely paralyzed. A neuromuscular blocking agent, commonly rocuronium or succinylcholine, has been injected. These compounds intercept the signals traveling from nerves to muscles. Your brain can dispatch commands all it likes. Your muscles will not obey. This paralysis serves a dual purpose. It relaxes the jaw and vocal cords, making intubation smoother, and it eliminates any possibility of involuntary movement during the procedure. Even people who are deeply unconscious can exhibit reflex responses. That's unacceptable when a surgeon has a blade inside you. So at this stage, you are unconscious, immobilized, and mechanically ventilated. But the anesthesiologist's work is far from over. Sustaining your unconscious state demands continuous, unwavering attention. The approach used is called balanced anesthesia, typically a blend of inhaled anesthetic vapor, such as sevoflurane, and intravenous agents. These are fine-tuned constantly in response to surgical events and your body's reactions. Blood pressure tends to fall during surgery. That's expected. Anesthetic drugs cause vasodilation. Your blood vessels widen, blood settles into your limbs, your heart encounters less resistance, and pressure decreases. If it dips too far, vasopressor medications bring it back up. If the heart rate slows excessively, atropine is given. If it climbs too high, beta blockers are used. The anesthesiologist is perpetually making minute corrections to hold your vital signs within a safe corridor. And here's something most people fail to appreciate. This person is not multitasking. They're not scrolling through messages or making small talk. Their complete concentration is fixed on you. They're tracking dozens of variables at once: oxygen concentration, carbon dioxide output, ventilation pressures, cardiac rhythm, body temperature, depth of sedation, the sound of air moving through your lungs, the rise and fall of your chest, pupil responses, skin warmth. Every data point tells them how your body is coping. The operation continues. The surgeon does their work, and you are somewhere else entirely. Not sleeping, not dreaming, simply absent. Research has demonstrated that under adequate anesthesia, the brain does not produce dreams. There isn't sufficient neural activity for it. You are not asleep in any ordinary sense. Normal sleep is an active, dynamic process in which the brain progresses through distinct phases. Dreams emerge during REM sleep. None of that occurs under anesthesia. Brain activity is muted, suppressed. There is nothing to recall because nothing is being lived. Unless something goes wrong. On rare occasions, the anesthesia proves insufficient. The patient begins to surface. Telltale indicators appear: tears forming in the eyes, a quickening pulse, faint twitches. If the paralytic agent has partially faded, the response is immediate. Anesthetic depth is increased. But in that narrow window, patients can occasionally register sensory input. They hear voices, they feel pressure or pain. And because they remain unable to move or cry out, the experience is harrowing. This is anesthesia awareness, and it is precisely the reason brain monitoring technology exists. EEG-based systems that read your brain's electrical patterns and gauge how deeply unconscious you truly are. But let's address the moment that frightens people the most: coming back. The surgery is wrapping up, the wound is being closed, and the time has come to return you to the waking world. The anesthetic vapors are discontinued, intravenous agents are tapered, the body is given time to break down whatever remains in circulation. The drugs begin to clear, neural activity starts climbing. You are making the transition from that suppressed state back toward awareness. But you're still paralyzed, still intubated. This is a delicate interval. You need to regain enough alertness to breathe independently, yet the breathing tube cannot be withdrawn until your protective airway reflexes have re-engaged. Premature removal carries the risk of aspiration, gastric contents finding their way into your lungs. So the anesthesiologist observes, watching for evidence of returning consciousness, limb movement, reactions to spoken instructions. Give my hand a squeeze. Try opening your eyes. Take a big breath in. When those responses materialize, when there's sufficient confidence that you can safeguard your airway and sustain adequate respiration, the paralytic is counteracted. Sugamidex or neostigmine is administered. These agents reverse the neuromuscular blockade. Muscle function returns. You begin drawing breaths under your own power. The ventilator continues providing support, but your independent respiratory effort is evident. Then the tube is withdrawn. The anchoring balloon is deflated. The tube is drawn out of your trachea. You cough. You may retch. All of this is normal. You likely won't recall it. Residual drug-induced amnesia obscures these moments, but it occurs. And in those initial seconds after extubation, the anesthesiologist remains at your side, still vigilant, confirming your breathing is adequate, verifying your oxygen levels hold steady, ensuring you're safe. You're conscious now, more or less. You've entered what's called emergence, that hazy borderland between unconsciousness and full lucidity. You may be disoriented, restless. Some patients surface in a state of agitation, flailing and combative. It's known as emergence delirium. Others come back gently, serenely. Every individual differs. But you're breathing independently. Your heart is maintaining its own rhythm. You've been brought back from the other side. You're transferred to the recovery area, the PACU, or post-anesthesia care unit. Nurses keep close watch. Supplemental oxygen continues to flow. Monitors still display your blood pressure, heart rate, and oxygen saturation. And gradually, across the next hour or two, you return fully. The fog of amnesia dissipates. You orient yourself. You recall your name, your location, what brought you here. But there's an aspect of this experience that rarely receives the attention it deserves. What you just underwent was extraordinary. Your consciousness was switched off. Your body was rendered motionless. The most fundamental processes sustaining your life, breathing, circulation, were handed over to machines and pharmaceuticals. Your body was opened. Your internal organs were handled. And then you were reassembled and awakened. You traveled to the very edge of death and came back. And for most people, there's no recollection of the journey, just a blink. One instant you're counting down from 10, the next you're blinking awake in recovery. But that void, that blank space in your lived experience, some people find it profoundly unsettling. Where were you? What becomes of consciousness when it's switched off? Does it relocate somewhere, or does it simply stop existing? These questions belong as much to philosophy as to medicine, and no one can answer them definitively. Brain scans can be interpreted, neural patterns can be quantified, but what happens to you, to your inner experience, to the quality of being aware that you are alive? That remains a mystery. Some patients report near-death experiences, particularly those who encountered complications. Cardiac arrest while under anesthesia, clinical death. They describe vivid visions, encounters with deceased loved ones, a pervasive, overwhelming sense of peace, passage through corridors of light. Skeptics attribute these to cerebral hypoxia, insufficient oxygen triggering hallucinatory activity as the brain powers down. Those of faith regard them as evidence of something beyond the material world. Both viewpoints coexist within the walls of every hospital. I recall hearing about a patient whose heart ceased beating during what was supposed to be a straightforward procedure. The team performed resuscitation efforts for close to 7 minutes. Chest compressions, epinephrine injections, electric shocks. They restored his heartbeat. And when he regained consciousness, he told the medical staff he had been somewhere else, somewhere tranquil. He said his deceased grandmother was present. She smiled, told him there were still things left for him to accomplish, and then he felt himself drawn back. Was that genuine? Was it his oxygen-starved brain assembling consoling imagery from stored memories? Nobody can say with absolute certainty, but he was convinced it was real, and the experience transformed him. He returned a different person, less fearful, more assured of something he couldn't quite articulate. The hazards of anesthesia are genuine. Death under anesthesia is uncommon but not impossible. The rate is roughly 1 in every 200,000 to 300,000 cases. It climbs if you carry significant health burdens, cardiac disease, pulmonary conditions, advanced age. But for otherwise healthy individuals undergoing standard operations, the risk is vanishingly small. Statistically, you face greater danger on the drive to the hospital than from the anesthesia itself. However, complications that fall short of death are more frequent. Allergic responses, respiratory difficulties, hemodynamic instability, intraoperative awareness, post-surgical nausea and vomiting, a raw throat from the intubation tube, mental confusion and disorientation, particularly among elderly patients. These events happen. They're addressed and managed. The team anticipates them, but they constitute part of the honest reality of undergoing anesthesia. There is a gravity to this work, a weight that never lifts and never becomes more comfortable to bear. Every single case matters. Every individual patient matters. The anesthesiologist cradles your life in their hands for every minute you spend unconscious. An error can be fatal. A lapse in monitoring can precipitate catastrophe. People ask whether that degree of responsibility ever becomes daunting, whether self-doubt ever surfaces. And the truthful answer is yes. Not in a way that breeds incompetence, but in a way that sharpens vigilance. The moment that constructive apprehension vanishes is the moment someone ought to walk away from the operating room. Because that fear, that productive, grounding fear, that profound respect for the enormity of the act, is precisely what keeps patients safe. So when you undergo anesthesia, understand this. You are in the care of someone who grasps the full weight of what they're doing. Someone who spent years training to handle every conceivable complication. Someone who will maintain absolute focus on you for the entirety of the procedure. You are not merely another case number. You are a human being, a life, somebody's parent, child, partner, friend. And guiding you safely through surgery and back to wakefulness, that isn't simply employment. For the people in that room, it's a vocation. The enigma of consciousness, the capacity to suppress it and restore it, the burden of balancing life against death. That is the essence of what happens when you go under anesthesia. And my hope is that now, armed with the truth, you can approach your surgery with diminished fear. Not because risk has been eliminated, it hasn't, but because you comprehend what's taking place, because you know someone is standing watch over you, because you know they've done this thousands of times before, and they will guide you back, just as they always have. If this explanation proved valuable, if it shed light on what truly transpires inside that operating room, share your thoughts below. Tell me what aspect of anesthesia frightened you most. Tell me what you wish someone had explained before your own procedure. And if you're heading into surgery soon, know that it's entirely acceptable to raise questions, to voice your fears to your anesthesiologist. They want you to feel as secure as possible, because your confidence in them, that is something they never treat lightly. I'm Dr. Dan Carter. Look after yourselves. I'll see you in the next one.